Thank you for joining, everyone. We're going to get started in about a minute or two.
Hi, everyone. Welcome. We'll be starting in about a minute. We're just having a little fun looking at all these folks from all over the country, saying who you are and where you're from. We got folks from Hawaii and California and Texas and Puerto Rico. Lots of folks from Hawaii. Oh, perfect weather in Hawaii. Nice.
And Amy, I'm just going to let you cue me whenever you want to get started.
Oh, it is the hour, so you all go ahead. Thanks for introducing yourself, everyone. It's really fun looking at where are calling in from.
Thanks, Amy. All right, before we get started, participants can enable subtitles by clicking on the closed captioning icon within the Zoom toolbar, which is located at the bottom of your screen. This presentation is also being simultaneously interpreted into Spanish. To listen in Spanish, excuse me, locate the globe-shaped icon, again located within the Zoom toolbar at the bottom of your screen. Click on it and select Spanish from the menu. And I'm going to assume that if you're listening in Spanish, you want to also see the presentation in Spanish. So to view the Spanish language slides, you can, at the top of your screen, you will find a tab labeled Español. Click on that tab to view the Spanish presentation. Welcome to today's session, From the Field to the Clinic, Recognizing Pesticide-Related Illness in Children. My name is Marta Alvarado. I am Manager of Online Education for Migrant Clinicians Network. And before we get started, I'm just going to go over a few housekeeping items with you all. This session is being recorded in both English and Spanish. Later today, you will receive a follow-up email that will contain links to the recordings, the post-session evaluation, and a PDF of both the Spanish and English presentations. If you have questions at any time during the presentation, please enter them in the chat or the Q&A. And a quick reminder, because this is being interpreted to our presenters, to please speak a little bit slower than you normally would to allow time for the interpreters. And this session has been approved for continuing nursing and medical education by the American Nurses Credentialing Center and by the American Academy of Family Physicians. If you would like to receive a certificate of continuing education or a certificate of successful completion, submission of the post-session evaluation is required. Migrant Clinicians Network has no relevant financial relationships that relate to this presentation, nor do we have any relevant financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. And Migrant Clinicians Network is proud to be at the forefront of responsible innovation and education, integrating technologies such as artificial intelligence to support the development of our accredited continuing education activities. MCN discloses the use of AI applications for graphic design and content support in this activity. Before we continue, I'm going to go ahead and hand it over to, I believe I'm handing it over to you, Esther, do the introductions.
Yes, thank you so much, Martha, and thank you
Thanks,
everyone
everyone.
for being here. Today we have some amazing presenters that are going to be joining us. First and foremost, we have Dr. James Roberts, who is an award-winning professor of pediatrics at the Medical University of South Carolina, where he has served on the faculty since 1997. Dr. Roberts is a nationally recognized physician who's been recognized for his work in pediatric environmental health, particularly in the areas of lead poisoning and pesticide exposure. He is a former member of the American Academy of Pediatrics Committee on Environmental Health, contributing to national policy statements, technical reports, and multiple editions of the AAP Handbook on Pediatric Environmental Health. His expertise has shaped state, federal guidance, including CDC recommendations and the EPA's recognition and management of pesticide poisoning, which is one of the resources that we are going to be covering here in the session today. Our second presenter is going to be my friend and colleague, Amy Liebman, who currently serves as MCN's Chief Program Officer. She has devoted her career to improving the health and safety of disenfranchised populations. She has joined MCN since 1999, where she has established nationally recognized initiatives to improve the health and safety of workers and their families. She currently oversees numerous programs ranging from integrating occupational and environmental medicine into primary care to community-based health and safety interventions. She is also a national leader in addressing worker safety through community health worker models, and she has spearheaded national policy efforts to protect farm workers and their families, and also has served on federal advisory committees for the EPA. She has recently, in 2024, been recognized and honored with the Shelley Davis Humanitarian Award. So with that, Amy, I'm going to pass it over to you.
Thanks, Esther. Can we go to the next slide? Hi, everyone. It's really exciting to have you all on and to be with you today. We're just going to start off just to make sure that you know how to use our poll feature. We just have a quick question for you to fill out. What is your profession? We'll just give it a few seconds here. Esther, I'll let you make the decision, Esther, when to stop it,
Yes,
you're in
absolutely.
charge.
So it looks like we have 73% of participants who have responded. If you're not able to respond to the pop-up poll, please respond in the chat. All right, we're going to go ahead and end it at 81%.
Oh, excellent. Excellent. We got a variety there, Dr. Roberts. So hopefully we'll meet all of your needs. Next slide. So today we're going to be talking about recognizing the signs and symptoms of pesticide exposure in children and adolescents, including some common exposure routes. We're going to be identifying common pediatric exposure scenarios, both in rural and agricultural settings. And also, we're hoping by the end of this that you'll be able to describe and identify some patient and clinical resources that will help you with the recognition and management of pesticide-related illness. Next slide. We'll be talking a lot about this book that Dr. Roberts wrote. It's The Recognition and Management of Pesticide Poisonings, the 6th edition. And when you registered for this webinar, you were given a link to it. It won't be the end of the world if you don't have the link to it or you haven't downloaded it, but if you have had a chance to download it, we'll be referring to this book throughout, and afterwards will be plenty of opportunities to access this book. Next slide. All right, I'm going to hand it over to Dr. Roberts.
All right, thank you, Amy. This is really exciting for me. I'm coming from Charleston, South Carolina, and I've never done a webinar before that is simultaneously translated in Spanish. And so for the interpreters, please let Esther know if I need to slow down. I did have a moment of panic because when Amy was going through her slides, I was seeing slides in Spanish, but luckily I figured out how to switch that over, so I'm with you now. Starting with just general pesticide exposure data, this is an old figure, but 10 to 20,000 occupational exposures per year in the U.S. have been reported. However, this is really a vast underreporting because there's an incomplete surveillance system. Most of the exposed workers are Latino farm workers, many of which are not going to say that they are exposed or report that. We have over 1 billion pounds of pesticides used every year in the U.S., mostly in agriculture. We have about 3 million poisonings worldwide, 200,000 deaths. Again, if all cases were counted, we're seeing 25 million poisonings in the US. I'm sorry, in the world. 98% underreporting, though. So we really see the tip of the iceberg that reports into the healthcare communities. There's a lot of things to cover, but I think if you were able to remember just one thing from this presentation, it's going to be this. I'm in pediatrics, and so I look at pediatric data a lot, but this really goes for any adult or any age group. But data from children indicate that 80% of children who had organophosphate poisoning were sent to the referring hospital with the wrong diagnosis. So acute pesticide poisoning may not be really common when you look at the grand scheme of all kinds of poisonings, but to really figure it out, you've got to have a high index of suspicion that it may be pesticide poisoning. So we're going to talk about a couple of cases. This first one is a 4-month-old child presents to the emergency room, and the baby's somewhat fussy, decreased appetite, been vomiting, kind of lethargic and limp. The family or the EMS providers report that en route the baby's eyes rolled in the back of the head, so maybe had some apnea and seizure. On exam in the ED, the baby was limp, had meiosis, poor respiratory effort, increased amount of secretions, did have a rapid heart rate though. So what's your diagnosis? And this can also be entered in the chat. It's really not going to be a poll question, and you can just think about it yourself. But I do want to give you a little more information while you're thinking about what you think the diagnosis might be. So on further history, this baby actually had some previous admissions, one of which they suspected organophosphate poisoning. The baby's had sepsis workups that were negative. In this particular visit to the ICU, the baby received some fentanyl, pralidoxime, and atropine. Was found to have decreased levels of the red blood cell and plasma cholinesterase levels. They were able to get some initial urine, blood, and breast milk samples that were negative for pesticide metabolites. Now, in reality, this is really more of a send out lab, so they're not getting this in real time. But this is just to kind of really try to summarize all of the data over the course of this hospitalization. While the baby was stabilized in the hospital, they did some investigation of the dad's home site and the work site. So this is a case of organophosphate poisoning. And just to give you a little bit of background here, what happens is that you've got the pesticide that phosphorylates the acetylcholinesterase enzyme. And so that excess accumulation accumulates in the nerve ending, and you get hypersecretion, which is the muscarinic symptoms. You get salivation, you get lacrimation, the bronchorrhea, the perspiration, the diarrhea. This is that classic, as we sometimes will say in medicine, running at all orifices. However, this presentation is a little less common in children. One thing you can sometimes see early on in the poisoning, though, is that you might get a little bit of nicotinic effects early before the muscarinic symptoms start to occur. And then also you can also find later some inhibitory paralysis, which is usually more of a delayed finding in some organophosphate poisoning. Centrally, you get behavioral disturbance, incoordination, respiratory depression, coma, and seizures. In the autonomic system, you'll get bradycardia, which is the classic finding. But again, this baby had a little tachycardia early on. And so what was happening is those nicotinic receptors were getting stimulated, and that's what caused the tachycardia. Most cases of cause of death is due to respiratory depression. And this is also where children aren't the same as adults. So In some data systems, you'll see children who have seizures far more often than adults, and definitely more often the pediatric patients are going to have lethargy and coma. As far as treatment, it does depend on recovery of the new enzyme, so you got to generate that. Definitely need some supportive care with airway support, oxygenation, ventilation. One of the antidotes is atropine, and that'll reverse some of the cholinergic effects. You do need fairly frequent and high doses, much more than you would normally do for any treatment of atropine. However, the atropine is not very effective against the nicotinic or the CNS symptoms. And so the pralidoxime is what will reactivate your acetylcholinesterase enzyme. And then, of course, you also need to address any kind of exposures and report the incident. So data from the infant's home environment. They tested samples from the trailer where they lived, and they found residues from two different organophosphates, excuse me. They also submitted some samples of the infant's urine, again, to CDC lab, and they found metabolites for acephate and other dimethylalkyl organophosphates. They also set up a decontamination room kind of away from the main living area so that the parents or the dad and uncle came home, they had a place to eat, change clothes, and also had them not shower before touching the baby. In medical school and residency, we really don't learn a lot about environmental health issues in general. Some surveys have looked at the topics. In medical school, for example, you might have 7 hours of environmental health education over the whole 4 years of med school. In U.S. residency programs, most spend an average of about 2 hours on environmental health related material. Definitely depends on the faculty themselves. If there's nobody in that faculty who are experienced with environmental health, then those residency programs pretty much get zero information on environmental health topics. A sampling of clinicians who participated in migrant clinician network programs, 78% said they had less than 2 hours of environmental and occupational health training. As far as physician and medical student knowledge of pesticides, the way that most are taught is by learning clues in the history and physical exam to really recognize the poisoning. But what actually happens is they're recognizing certain symptoms and they're creating a differential diagnosis. And they may or may not include those pesticides in their differential. And then my own experience is talking with students, residents. When I mention the word pesticide, they think only insecticide, which is probably the more common ones, but they don't think anything about herbicides, fungicides, rodenticides. Most of the students and residents can recall generalities of organophosphate poisoning. That is one of the few things that does get covered in the pharmacology class. And the reason there is because there's an antidote for treatment for that. But nobody can tell a difference between the organophosphate poisoning signs in kids versus adults. And if I ask them to give me a differential of pesticide exposure, pesticide poisonings, they're going to start with organophosphates and probably end right there. This is a long list of commonly presenting signs and symptoms. We're going to talk a little bit more about seizures in a few minutes. Nausea, vomiting, diarrhea are really common. A lot will have respiratory distress and pulmonary edema. Some might have headaches. Some agents will cause a lot of skin rashes and other skin findings. And then several of them will have some effects on the cardiovascular system. It's really important, though, to understand exposure to family members, and that's where an occupational history is so important. You want to ask about take-home exposures. You want to ask where they work, if they're working in the fields or not. Is there drift from their fields to their house? Is there housing right next to some of the fields? For non-farm worker families, what types of applications might they use on their own garden and home, and the other lawn and vegetable gardens as well? We're going to do a second case now, and this is going to change to an older person. So we got a 17-year-old who's presenting with mental status changes. This patient's semi-comatose, brought in by EMS. The initial complaints, though, were burning, stinging, and numbness on the hands, arms, and face after working out in the fields. All right, so I already gave you a clue. This is another pesticide poisoning. Of course, it's subject to the whole webinar, but even with that clue, is there anything that somebody's starting to think of that's other things besides organophosphates? And if you want to put in the chat, I'm kind of watching that because that's popping up every time I'm speaking. This patient also had headaches, dizziness, nausea, vomiting. Mental status changes occurred. Initially not really sure what he was exposed to. So we got possibility of an herbicide, an allergic reaction, as somebody said on there. We do again see increased oral secretions. I love this one, just a big question mark. And most of us will have a question mark for a case like this because everybody's thinking this is organophosphate poisoning, and it's not. All right, so we got increased oral secretions, just like OPs. We got cyanosis and crackles. We got muscle fasciculations. This person also has some bradycardia, tachycardia, and then they start having seizures within about 30 minutes. All right. I kind of told you the answer to this poll question, but we'll try it anyway. So is this another case of organophosphate poisoning? And Esther, you can tell me if I just need to move on or if we're going to get
no,
that.
I just opened up the poll, so
All right.
let's just give it
Oh,
a
wait a
few
second.
seconds here. And there were some really great suggestions in the chat as well. We got
I'll
herbicide,
take some of
allergic
those. I might have
reaction.
missed some.
We're just about at 50%. Just one more second for folks to respond. And this is a yes or no. So if you're not able to respond on the chat or on the poll, feel free to respond in the chat, yes or no. Is this another case of organophosphate poisoning? Alrighty, I'm going to go ahead and end the poll and share the results.
Right. And am I able to close that out? Yeah, I can. Okay. All right. So a lot of you said yes. As far as coming into the emergency room, any emergency doctor seeing this patient would absolutely begin treatment for organophosphate poisoning. Absolutely. They did appropriate decontamination. They're protecting the hospital employees. They're providing airway support. They're controlling seizures with pralidoxine. They go ahead and start, controlling seizures with lorazepam, and they're starting treatment with atropine and pralidoxine while they await their cholinesterase levels. So let's reevaluate this patient here about an hour later. He's a little bit better. He still looks pretty sick. His skin is flushed and hot and dry. He's got mydriasis. He's got tachycardia. So he's fully atropinized. All right. So he's got plenty of atropine on board now. His seizure stopped. His cholinesterases are normal. And so a coworker was able to confirm the poisoning, and it's a cyanopyrethroid, cypermethrin. And this is really important and worth taking just a minute or two to talk about the pyrethrins and pyrethroids as a full class. These were worldwide use since the 1970s. originally derived from the chrysanthemum flower. You've got the short-acting pyrethrins, but then you've got the synthetically modified pyrethroids. And it's those pyrethroids that are very commonly found in consumer products, also used a lot in agricultural use. So we're going to use the book just for a minute to really explore a little bit more detail about pyrethroids. So if anybody does have that, either the book or the website, Chapter 4 starts on page 38, and this is a chapter solely developed for pyrethrins and pyrethroids. Although you do have to turn to page 40 to get a little bit farther along in the actual text of that chapter. And now we're going to look at your left side of the screen here where it has the highlights. And this could sort of be like the equivalent of your AI summary if this was done while AI was even around then. It wasn't, but kind of works that way now. So highlights of pyrethroids. First of all, it works differently than organophosphates. So it acts at the sodium and the chlorine channels and also on the GABA sites. And then the type 2, which I mentioned, is this one. This is a much more severe cases of poisoning compared to the other pyrethrins and pyrethroids. But interestingly, it has a lot of very similar findings that are in organophosphates. So there's fine tremor, there's severe salivation, hyperexcitability, may have dizziness, headache, fatigue, vomiting. But this one is the key part right here, the stinging, burning, numbness around the mouth, around the skin, or wherever else. It could be the mouth if you swallowed it. That is sort of the pathognomonic finding really with pyrethroids. And so that's really your clue as to whether you're dealing with organophosphates or something a little bit different. So again, in more severe cases, pulmonary edema, muscle fasciculation, seizures, and coma. Word for word, same things that can happen with organophosphate poisoning. Again, I just kind of points out the pyrethrin, the paresthesias with it, and that's very unique for pyrethroid poisoning. I want to briefly mention some other insecticides. The neonicotinoids, imidacloprid, has been on the market since the 1990s, as well as fipronil. Both of these groups are used pretty extensive. The neonicotinoids are used in agriculture and flea control. The fipronil was used in agriculture as well, but also lawn and a lot of household pet application. There's much less human toxicity with these two groups. I did want to mention it because they are, a lot of what they've done with insecticides is every decade or two, they start increasing with a different class of insecticides as we get rid of some of the insecticides. It used to be the organochlorines, chlordane, and things like that. Then came the organophosphates. Some of those have gone off the market. Then come the pyrethroids. We still see a lot of use of that, but a lot of toxicity with it. Then they developed the new nicotinoids and the fipronil. So that's a progression. And in this case, again, these two classes are more affinitive for the insects receptors as opposed to human receptors. So you do get less toxicity. Also in that book that you got either by the web link or a book in person is an index, which kind of helps really focus some people's thought process when they're trying to figure out what kind of differential diagnosis you might have. So this is an example on page 254 where we're looking at GI tract and specifically liver symptoms and, abdominal pain. And, you pick up abdominal pain on your next column or all the various pesticides that may be associated with that. And I'm just circling copper compounds as an example, not very commonly used, but if you're looking at these symptoms, you get a whole long list of potential pesticides with that. And again, with liver enlargement, again, copper happens to come up again as an example with that. So this is just really more of a explanation of how you can use this book and how you can use that index. I mentioned we come back to seizures because seizures definitely are associated with a lot of classes of insecticide or pesticides. I mean, insecticides I mentioned, and this takes the whole gamut of from the early organochlorines all the way to fipronil. If you ingested fipronil, that may be enough to give you seizures. So, but regular use doesn't give you as much human toxicity as the others. Rodenticides, strychnine is really old and hardly used anymore. Sodium fluoroacetate the same way. But these are all various rodenticides that would cause seizures. There's a few cases that some of the herbicides will cause seizures as well as some of the fumigants. All right, I believe, Amy, I think this is your section.
Doctor, before we continue on to the next section, I did want to just address a couple of the questions that were asked in the chat. We had Don Nicholson and Kathleen Fagan ask, how was the 17-year-old exposed? How does it enter the body? Is it breathing, ingestion, or skin exposure?
So the question is all of the answer is all of the above. First off, the second case was an amalgamation of many case reports. So we're trying to make just more of a teaching and learning case out of that. But in this case, you got a teenager who's working in the fields, and so you can get exposure across the skin. Certainly, the hand to mouth activity. If he's working and then doesn't wash his hands and eats his lunch, he's getting exposure that way. So orally ingested, and you can also inhale and get an inhalation exposure as well.
Great, thank you so much.
Great. And so I just wanted to follow up on some of the content that Dr. Roberts was talking about in terms of the what you want to collect in order to better understand what's happening with your patient. So if you can go to the next slide. So Dr. Roberts sort of went through the presentation, what was done, and this is going to go to a question that Blanca has posed in the Q&A. You know, okay, we figured out the diagnosis, we're doing the treatment. Are we done yet? Next slide. And so even sometimes, a lot of times that you may be in a situation where there's more than one person that is exposed, or even if it's not more than one person, collecting this information from the patient is really important. You want to understand what is the pesticide that they were exposed to. And so there is something called the pesticide label, and there's also a safety data sheet that should give the clinician a lot of information about the pesticide and what some of the side effects are. If you can get a copy of the pesticide application record, that would be really important. And then there's some suggestions to get some blood samples, a fresh urine sample, any contaminated clothing. Again, all of these may not help you in the moment, but may help this patient as things progress, and also may be really important in terms of getting workers' compensation. Like we said, there was a 17-year-old involved. That person was working. So all this information is really important to collect as you're trying to think about your diagnosis. Next slide. And MCN has a number of resources that can help you. Also, I helped Dr. Roberts in one of the chapters in the book, and there is an outline on some of the data that we suggest that you collect for the patient. And these are mostly in acutely exposed patients. Next slide, please. So, and this is where, so we want to know the information, and it's really important. We want to know the information on every patient. So if you have multiple patients coming in with the symptoms and you figure it out based on the first patient, you still want to collect all that data for each patient. And the question that is coming up with, like, what are the requirements then for reporting it? So, pesticide exposure is something that clinicians are required to report in many states. And if it's not required in your state, often the Poison Control Center can help you with that. So MCN, on our website, we have a map, a handy dandy map, which you can go to and say, oh, am I required to report a pesticide poisoning. And you click on your state. In this case, we're going to click on the state of Hawaii, I believe. Next, and luckily we have some folks from Hawaii and on our call. And yes, in Hawaii, you actually are required to report pesticide exposure. This reporting is really important and is part of the management of the patient. Because when we understand that a certain pesticide or a certain exposure situation is causing people to be exposed, it gives us a lot of information about that particular pesticide. And also maybe we collect information that that's not a great pesticide to be used in the way that it was. Maybe we should be using a different pesticide. Maybe it was used in an improper way. We don't know anything unless we understand that there's an exposure situation sometimes. And so reporting that exposure becomes really important. And Blanca brought up a situation, Dr. Roberts, where they had a pesticide exposure with second and fourth graders at a school, and that many of the kids had rashes and blisters and struggled to breathe. And the parents were looking for some advice about some of the longer term exposures, and we'll talk about that in a little bit. But they were also, not all the kids actually saw a doctor, and they were just told to call if symptoms got worse. But in many situations where there's a poisoning, it is really advisable, if it is possible, to see a healthcare provider and making sure that everything is getting documented and ultimately reported. Next slide. So one of the things that we're talking about here is we're talking about this pediatric population. And we had a situation where we had farm worker dad and uncle working and a baby at home. That is very common with our agricultural families and our farm worker families. But it's also really common that children do work in agriculture. And so recognizing that children could potentially be exposed just from the work that they in and of themselves are doing is also really important. And children can work in agriculture as young as 10 years old with parental permission. And so it is a little bit different than other industries in that a lot of younger kids can work in this industry. Next slide. So when it comes to pesticides, I'm just curious what you all think about knowing that children can work in agriculture. What is the minimum age that you're allowed to handle pesticides? That means to apply pesticides or go into a field that has been applied with pesticides. See
Okay,
what
we're
you
just
say.
we're just about at 50% response rate right now. Just leave it open for just a few more seconds. And if you're not able to answer via the poll, feel free to answer in the chat.
And Kathy, I'll get to your question in just a second here. Okay. Well, Ignacio got it right in the chat, and the majority of you got it correct. It is 18 years old is the minimum age to handle pesticides. So that's really important. That's a fairly recent change in the last decade because, next slide, please. Because of something called the Workers' Protection Standard. But basically, the minimum age that you can handle pesticides, apply pesticides, and do early entry into the field, something called REI, you have to be at least 18 years old. And it is really important in our communities to remember that if this is your own farm and it's a family's farm, members of an owner's immediate family are exempt from this requirement. Next slide. And the minimum age is brought to you because we have a regulation about pesticides. It's called the Worker Protection Standard, and it was strengthened in 2015. And MCN is very proud of the work we did in partnership with our allies and with EPA to strengthen the Worker Protection Standard. And it's intended to reduce the risks of illness and injuries to workers and handlers that result in occupational exposures to pesticides in the production of agricultural plants. And one of the things that we did in strengthening the worker protection standard is that minimum age. So prior to 2015, we did not have a minimum age for kids with pesticides. All right, next slide. So the basic, and I could do a whole other webinar on this. We're not going to get too deep into it today, but the basic framework of the worker protection standard, you can tell I'm really proud of some of the work we did around this particular regulation, is to inform, make sure that the worker is informed about pesticides. It's meant to protect workers from pesticide exposures, and there's pieces in the WPS about what to do in case of a pesticide exposure. And then just real quickly to answer Kathy's question, she wanted to know if workers that aren't authorized to work are in jeopardy in terms of some of those reporting requirements. And I think that's a really important piece when Dr. Roberts gave us some of the initial statistics about folks that are what we know, what data we know, what information we know about pesticide poisonings. There's a ton of really significant barriers from clinician education and recognition to clinicians being unaware of the laws, but also just the fear that many farm workers face in terms of reporting something, and that scenario is getting worse under our current immigration policy. So you are protected under the worker protection standard when you do report, but we do know that there's just a ton of barriers, whether that, even if those barriers are supposed to be reduced because of regulations. Next slide. All right, I think this is where I hand it back to you, Dr. Roberts.
Yep. All right, this next couple of slides, I mentioned earlier about drawing cholinesterase levels, which is a real-time diagnostic tool for managing pesticide poisoning. These others, though, these are really more research-oriented type evaluation markers. And they're also not readily available at most labs. But when you talk about measuring an organophosphate compound, you're really not measuring the parent compound. You're measuring the breakdown products from those compounds. In this case, you'll see chlorpyrifos, and that's got its own very specific metabolite, as well as parathione that has its own metabolite as well. And then within that cascade, you also will see various ones will go to diethyl metabolites or dimethyl metabolites. And those are actually what's being measured in the urine. And these are really more research tools, and I'm going to get to that in just a minute. The other one I want to just briefly mention is the pyrethroid metabolites as well. We can also measure that with a specific metabolite, 3-phenoxybenzoic acid, again, as a way of measuring exposure over time. So these are more often used in like epidemiological studies, for example, but also help us determine some chronic effects. We were actually really briefly, when we did the 5th edition, we just did all of the revision from the previous 4 editions, changed a lot of data and added a lot of data and definitely added a lot of references. But we were particularly proud of the 6th edition because we were able to convince the EPA that it's really important to include a chapter on chronic effects. And so that took a little bit of doing, but finally we got that in for the 6th edition. A lot of this is informed by epidemiological studies. The neurodevelopmental issue, Amy brought this up on a scenario that I was involved with on a school exposure, and I'm going to go a little bit off slides for a second. The scenario was that this particular classroom was being treated for termites, the ground below it, and they were attempting to drill downwards outside the building, downwards underneath into the foundation below the building, the classroom. Unfortunately, they missed by about 2 feet, and so they made their drill holes and they injected chlorpyrifos into the classroom pretty much on a whole bathing pattern that went the whole length of this classroom. It got worse because the school officials didn't tell the families right away what happened. And then after about 2 or 3 months, somebody mentioned it to their parents about these symptoms that they were having. And oh, yeah, by the way, our teacher had us help clean up the residue off our desks after this exposure. So it was a terrible exposure, developed into, long-term issues for some of the kids. Again, that was not a study. It was just a scenario that I was involved with from the periphery after the fact. It happened 3 months later. But it kind of also sets the stage for what I'm going to mention about some of these longitudinal neurodevelopmental topics, including memory and cognitive development, reasoning, and IQ. I have a slide there in a minute to talk a little bit about ADHD and autism. Birth defects have also been found in some of the epidemiological studies. More often is going to be cleft palate and some heart defects. And then cancer has also been studied from a childhood standpoint with leukemia, but also from an adult standpoint with prostate cancer and non-Hodgkin's lymphoma, among others. So again, this is not to take away the adult cancers, highly important, highly relevant as well. As a pediatrician, I'm a little drawn to the children though, and the pediatric cancers. There's been associations with leukemia and brain tumors with numerous epidemiological studies. The most common risk factors are going to be parent exposure, family pesticide use, and then parental exposure during or before pregnancy. And I want to just kind of point out the very bottom of the slide. It's hard to tell, but I'm assuming that you'll have access to the slides. But these are two really good review articles. They are one's from 1998, one's from 2007, but highly recommend reading those two articles. Gives you really good information about some of the cancers. This question in the chat I just saw, is this why we're seeing more leukemia in children? I think that there's many reasons we see leukemia. Could it be pesticides? Certainly. Could it be other environmental exposures? Certainly. Could it be genetics? Absolutely. And some chance as well. But, I think it's the tip of numerous things that may be in that cause and effect realm. And actually, I have to go off script again by reminding myself and everyone on this call that epidemiological studies do not prove cause and effect. In order to get cause and effect, the really gold standard is a randomized controlled trial. And we're obviously not going to randomize kids to pesticide and to a placebo. And so when you get multiple epidemiological studies that all find some of the same findings, that becomes more of a strength of evidence. So that's about as close as we can get with epidemiology to show cause and effect. We were told that leukemia was not genetic a few weeks ago by a doctor in Seattle. Most of that is correct, but AML does have as a genetic component with it. All right, autism and ADHD. So there's a lot of mechanism effects with pesticides and altering brain development. There's this critical window of development and exposure, and certainly the genetics and the environment together work hand in hand. For as far as ADHD specifically, there's one case control and 7 cohort studies that we looked at prior to 2019 that demonstrate inattention, behavior, and diagnosis of ADHD. And most of those are related to organophosphate metabolites, specifically chlorpyrifos in some studies, and also a couple of other DDT and other organochlorine pesticides. And then with autism, similar kinds of cohort studies, 2 with organochlorines and 4 with organophosphate metabolites, have demonstrated associations with autism or pervasive developmental delay, the latter of which is sort of that beginning feature for for autism development. All right, so what do? We're going to recognize the parent's occupation, the teenager's occupation as well. We're going to hopefully recognize and treat some forms of acute poisoning. Remember to report the cases of exposure, promote primary prevention, asking about take-home exposures, and then becoming involved in local and state and federal policy. So pesticides might have both acute and chronic effects. There's a higher short-term exposures, most often with acute effects. Chronic effects may occur after a high exposure, such as the scenario I described with the school classroom, or more of a subacute or chronic exposure. And then acute effects may or may not be specific. And you look for those helpful patterns, unique symptoms, and you need a high index of suspicion. And I believe that the next couple of slides are with Amy.
Yes, I'm gonna thank you so much. If you want to take a quick look at some of the questions, Dr. Roberts, and making sure that we're answering them as we go. But I just wanted to share with you resources, and Migrant Clinicians Network has a number of resources, and many of our partners have resources that will be really helpful for you as we address pesticide exposures. You know, some of our most popular resources are our comic books, our educational comic books. We have a number of pesticide-related comic books. Some deal with workers and the worker protection standard and outline in a really easy to understand way and in Spanish what to do around worker protection standard. We also have a comic book that looks at how kids are exposed and what children can do to minimize their exposures. We also have all these resources are on our webpage. I showed you the map already that you can go and find out what the requirements are in your state to figure out if you're required to report pesticide exposures. And again, if you're not required, the Poison Control Center is a really good resource for you to let them know about something happening in your patient population. There's all kinds of links to download these comic books, and then there's the clinical tools that we mentioned. There's the link to the book that we've talked about quite a bit here, as well as just other resources such as the National Action Plan that MCN has been a part of in safeguarding children in agriculture. So I encourage you all to visit our website and take a look at our pesticide resources. And we're working really hard to actually update many of our resources and improve our webpage. So it's a work in progress, but a lot of those resources are there for you now. Next slide, please. Also, for those of you who are interested, we're on Substack, and you can get a lot of information about pesticides, as well as other information that MCN and other activities that MCN is doing. Next slide, please. And then I did want to mention the pediatric environmental health specialty units, particularly because they were focusing on kids. And every EPA region has a pediatric environmental health specialty unit. This I mentioned the Poison Control Center. This is a great resource for any clinicians and community health workers that have questions or need help with any of the pediatric cases. So I encourage you to visit the PACU website and reach out to your PACU if you have any questions involving PACUs in your pediatric issues in your community. And it doesn't just deal with pesticides, it's pediatric environmental health. Next slide. Here's a bunch of QR codes as well as links, but we really encourage you to connect with us and reach out to us with information that you need and like. So couple things. So right now, that's pretty much the end of our presentation. So we have time for a couple of questions. Dr. Roberts, did you see any
I did.
oh, and also, yeah. And before I
I
let you answer them, make sure you take a moment to fill out our evaluation. We'll be putting the evaluation link in the chat. But go ahead, Dr. Roberts.
Yeah, I remember this question coming in right when I was wrapping up something about the signs and symptoms X index, and then I think that went over to your section. So the question that came in was, are the signs and symptoms shown in the index present in same both in adults and pediatric patients? And great question. And the quick answer to that is that most of them relate to adult patients. Um, a lot of that is dependent on the data that come in. And when you're doing evaluations or literature searches on many pesticide cases, often they're adults, and oftentimes they're farm workers, sometimes they're suicide attempts. And so that was how it was mostly compiled. The big exception being what I mentioned about organophosphates in pediatrics and adults with the CNS symptoms, the seizures, coma, et cetera, far more likely to occur in children than in adults. There was a couple of questions for you, Amy, about undocumented farm workers in jeopardy with reporting requirements, and then reporting requirements for employers to educate their workers on pesticides. If you want to do those, I know there was some that came in later after you finished, and I saw a bunch of
Yeah.
comments. I haven't looked at them all yet.
So I just want to be clear that regardless of one's authorization status, the worker protection standard applies to all workers. So it talk about is that the fact is that one's documentation status presents some real world fears that is legitimate, and workers might be very scared to report any signs and just report a pesticide exposure in general. So we really need to make sure that we're doing all of the outreach, the education, the support, so that we are making sure that farm workers are as protected as they possibly can be from pesticide exposure. And then the WPS, again, we can do a whole other webinar on this, but the work protection standard does have requirements that employers are supposed to train the workers on how to protect themselves from pesticide exposure. There's a significant training piece in the worker protection standard. And again, stay tuned. That might be a topic for another webinar coming up within the next year regarding the specifics about the worker protection standard, and also making sure that you're aware of all the resources that we have that you can train workers around the worker protection standard and how to protect themselves and their children from pesticides.
And I'm looking at one other question for me. The question was your thoughts on PFAS and pesticides. And I think that they're two different things for one thing, but a lot of the PFAS data are starting to also demonstrate some potential for neurodevelopmental effects as well. Again, it kind of goes back to that multi things that can be all in the cause and effect model for various outcomes. PFAS are separate from, these are chemicals that are, again, don't really degrade in the environment, become accumulated in tissue, and you can now see more higher levels in pediatric patients and adult patients as well. So that's going to be, I think, a lot more data coming out on the PFAS in the next few years, actually.
And we have two more questions in the Q&A that came in. Have you seen any issues manifest from more chronic organophosphate exposure rather than acute poisoning? And then the second question was, can you share any research on the impact of neonic, and I believe they're referring to neonicotinic pesticides on children?
All right, can you repeat that first question, Esther?
Absolutely. It was issues manifesting from chronic organophosphate exposure rather than acute poisoning.
Yeah, so a lot of the neurodevelopmental effects, again, some of the epidemiological data, one of the kids in that classroom, all of which had, well, his might have been a subacute. None of the kids in that classroom developed severe acute poisoning that led them to go to the emergency room. But they definitely had what I would call a subacute exposure for sure. And they did have some chronic symptoms that might suggest, or some acute symptoms that might have suggested flu-like symptoms, which could be similar to mild cases. And some of those kids went on to at least describe and experience some levels of ADHD type neurodevelopmental effects. Now, anybody could go back and say, well, were they already going to have problems to begin with? Probably so. A couple of kids that I've been involved with over the years did have one in particular had an ongoing seizure disorder, which we think might have been also related to their poisoning effects early on in life. And so I think that there definitely is some effects from those who have an acute poisoning can go on to have chronic effects, and those who don't have acute symptoms but can still go on to get chronic effects. And then that was a long answer to that question, but I think it's really important to distinguish and talk about. And if you remind me of that last question again, please.
Yes, the question was on sharing any
Mhm.
research that you may have on the impact of neonic pesticides on children. But just because we're running out of time, I'm just going to suggest that we respond to this question later. And I have a few more things that I can share with you all. We are looking for reviews. If you love our work and if you love this webinar especially, feel free to leave us a review on Great Nonprofits. And here is the contact information. Thank you all so much for joining us today. Thank you, Dr. Roberts, and thank you, Amy, for such great information. If we were not able to get to your question today, we will be conducting some follow-up. Thank you so much.
Yeah.
Thanks for
And
doing it.
Esther, I wanted to just say like some of the questions that are coming in are pretty good. And I encourage you all to join our Substack and make sure that you're on our streamlined mailing list. Because when you guys ask questions like the one that we'll follow up with, how can we make sure providers are using the right ICD-10 codes? Those are really good questions for us, and we can actually do a little bit of writing to help answer those and put them out in different venues. So if we didn't get to all of your questions today, we will try to get to them either via you directly through email, or we'll see a future Substack issue on these topics.
Thank you,
Thanks
everyone.
everyone for joining us.
Before I close
Tanya-
out, I just want to say thank you to our interpreters, Tanya and Luis. Thank you so much for your interpretation services. Highly appreciate it. Thanks, everyone.
Thank you so much.
Thanks. Bye.